Good morning, everybody. Over the next 20 minutes, we are going to make an overview of thyroid cancer. The program for this presentation will include some definitions and the classification of this disease based on anatomical classification. We are going to discuss thyroid cancer as a public health problem. We'll discuss the principles of therapeutics, in particular for follicular and papillary thyroid carcinomas. We'll review some of the prognosis risk factors, and finally, we'll make some conclusions on this particular disease. From a histological perspective, as you know, thyroid carcinomas could be classified in different types. We have the differentiated thyroid cancers of follicular origin that include the papillary, follicular, and hardle cell thyroid carcinomas. They represent about 90% of all cancers that we see in clinical practice. We also have the poorly differentiated thyroid carcinoma and the anaplastic thyroid cancers that, similar to the others, have also a follicular origin, simply that the tumors are more primitive, histologically speaking. We have medullary thyroid carcinoma, which is a neuroendocrine tumor coming from the C cells. From a histological perspective, papillary thyroid cancer is the most common one. Approximately 80 to 85% of total thyroid cancers that we see in clinical practice are represented by this histological variant. This is followed by follicular thyroid cancer, which is responsible for 10 to 15%, and then after by hardle cell thyroid cancer here in green, that is responsible for maybe 2 to 4%. Neuroendocrine tumor, in this particular case, medullary thyroid cancer, is responsible for 3 to 4%. Unfortunately, anaplastic thyroid cancer is the less common of them, happening in less than 1% of these patients, being this one the most aggressive cancer that any human being can have in general. Let's discuss thyroid carcinoma as a public health problem. The incidence of thyroid cancer in many countries around the world has markedly increased over the last decade, and this is an example in the United States. According to the American Cancer Society, in 2008, if you look at the incidence of thyroid carcinoma, this one has practically doubled when compared to the incidence that this disease had in 2001. What are the implications of this? In 2001, only 15,000 new cases of papillary thyroid carcinoma were discovered in a country of more than 300 million people. So by then, papillary thyroid cancer, or thyroid cancer in general, was considered a rare condition. However, by 2008, it has become a much more common condition in clinical practice. Therefore, we have to pay more attention on how we treat and we follow and we diagnose patients with this particular disease. By 2013, it was quite interesting to see that the incidence of thyroid cancer quadrupled in the United States. Approximately 60,220 new cases of thyroid cancer were identified in the general population, making of thyroid cancer number 9 in incidence in the United States, one of the top 10 cancers in epidemiological characteristics in this country. Of interest, thyroid cancer became number 5 in women after breast cancer, lung and bronchi cancers, colon and rectal cancers, and uterine body cancers. In men, thyroid cancer is not yet one of the top 10, but we anticipate that over the next 2 or 3 years, it's going to become one of the top 10 cancers in clinical presentations in the United States. Now, when you look at the incidence according to histological characteristics, you will see that it's only one particular type of cancer, the most common one, the one that has been associated with an increased incidence, and this one is papillary thyroid carcinoma. In this graphic, you are going to see in the y-axis the years in time in which the cancers have been diagnosed in this particular country in association with the incidence according to 100,000 population. What you will have here is in red, patients who have medullary thyroid carcinoma, in black, patients who have anaplastic thyroid carcinoma, and in blue, patients who have follicular thyroid cancer. And if you look at the incidence of all these 3 cancers, they have not changed over a period of time of approximately 30 years. If you look at the incidence of papillary thyroid cancer, which is here in purple, you will see that over the years, the incidence has markedly increased and overlaps with the increased incidence that we see in general in the population with thyroid cancer. So the one that is becoming a real problem is papillary thyroid cancer. Now, when you look at patients with papillary thyroid cancer, the ones that we see now more often are patients who have small tumors in clinical practice. And you can see it in this graphic. So in this graphic, in the left side, you will see patients who have tumors that are smaller than 1 centimeter. Together at the side of that one, you will see patients who have tumors that are in between 1 and 2.9 centimeters. Then patients who have 3 to 3.9 centimeters tumors. And finally, patients who have tumors that are larger than 4 centimeters in size. If you look at the incidence, it's the group of small tumors in which we have the increased incidence of papillary thyroid carcinomas. You can see that in patients who have tumors that are smaller than 1 centimeter in size, the incidence of this disease has markedly increased over the years, similar to what is happening for patients who have tumors in between 1 and 2.9 centimeters. In patients who have larger tumors, although there is an increased incidence, this one is not as dramatic as the one that we see with the smaller tumors. What are the possible explanations for this phenomena? Well, there are several possible explanations. Number one, the presence of environmental factors, such as radiation because of diagnostic, therapeutic, or non-medical purposes, and we are talking here mainly about sublethal radiation, levels of radiation that go in between 100 and 1,000 centigrades. Of course, chemicals are considered possible causes of an increased incidence of papillary thyroid carcinoma. In addition, another possible explanation is an increasing early and overdiagnosis of small tumors, and finally, a change in the spectrum of risk factors that are important for the risk for the disease development. Let's discuss each one of these in the United States. In regards to radiation and environmental factors, the only one in the US that has been clearly associated with an increased risk to develop papillary thyroid carcinoma is the exposure to radiation in sublethal concentrations. When that happened, historically speaking? Well, in the 50s, there were underground explosions in the state of Nevada, atomic explosions that caused radiation that went into the surface, and that radiation was responsible to papillary thyroid carcinoma in patients who live in that particular state. It not only happened in humans, it also happened in animals, and those radiation doses were associated with an increased risk of papillary thyroid carcinoma at that particular time. This is not currently the situation for most patients with papillary thyroid carcinoma in the US, as we haven't had those atomic accidents any longer. However, we see historical examples. We have the previous historical example given by the atomic explosions of Hiroshima and Nagasaki, in which for the first time we have an association of papillary thyroid carcinoma with sublethal radiation. And most recently, we have the example of Chernobyl in Ukraine, where people, especially located in the area of the Belarus, started developing papillary thyroid carcinomas. Unfortunately, because of political situations, we don't really know what is the outcome of that particular exposure to sublethal radiation therapy right now. Now, in regards to the second important factor, is it because we are having or we are doing radiographic studies more often than before that we see now an increased incidence of papillary thyroid carcinoma? And the answer likely comes from this particular graphic. In this graphic, you are going to see the role of the socioeconomic status in the United States in rising the incidence of small tumors, those in which we see that markedly increased incidence of papillary thyroid carcinoma. If you look at this graphic, you will see on the left side patients who have tumors that are smaller than 1 centimeter in size, and in the right, patients who have tumors that are in between 1.1 and 2 centimeters in size. You can see here the year of diagnosis, and when you look at the year of diagnosis, from 1995, you see an increase in the incidence of papillary thyroid carcinoma in the general population. What it is interesting here is that the increase in the incidence is associated with the fact that more Americans were having health insurance, and they were having evaluations by primary care physicians that finally led to the diagnosis of papillary thyroid carcinoma. In the case of patients who have tumors that are smaller than 4 centimeters in size, yes, we have noticed also an increased incidence. However, these tumors are not the ones that have been impacted by this particular phenomena. So what is the conclusion of these two slides? The conclusion of these two slides is simply that patients who have papillary thyroid carcinomas are likely more often discovered in the United States simply because we are doing radiographic studies that many times are not indicated for the evaluation of thyroid disease that by accident identified thyroid nodules that correspond to papillary thyroid carcinomas. Finally, let's talk about the biology characteristics of these tumors as a possible explanation of why we see in these patients an increased incidence of this disease. Well, when you look at papillary thyroid carcinoma, it is important to remember that the development of papillary thyroid carcinoma will have to do with mutations in a particular pathway. That pathway is the MAP kinase signaling. And the mutations that are located here are going to be responsible for many cases of papillary thyroid carcinoma. What is the MAP kinase pathway? The MAP kinase pathway is characterized by the presence of a receptor. This receptor is a tyrosine kinase receptor. It's a receptor that in order to get activated has to interact with a growth factor, and that interaction with the growth factor will imply the dimerization of the receptor with phosphorylation of the tyrosine kinase part. That phosphorylation may activate several factors intracellularly that are going to take a message inside the nuclei that will modulate the transcription of different genes that are important in the cell differentiation and the cell proliferation process. In the case of thyroid cancer, in particular in papillary thyroid carcinoma, we may have mutations in this pathway. The MAP kinase pathway under normal conditions activates RAS, followed by BRAF, followed by MEK, and followed by ERK. Well, in this pathway, we see mutations in patients with this disease. Those mutations are mainly located in BRAF and in RAS, and we can also find some rearrangements that we call the red PTC receptor, which is an abnormal tyrosine kinase receptor that is located in the cell membrane of patients who have papillary thyroid carcinomas. These mutations are mutually excluded mutations. What is the meaning of that? That if someone has a mutation in BRAF, you don't expect to see mutations in the others. If someone has a mutation in RAS, you don't expect to see mutations in the others. If someone has a rearrangement red PTC, you don't expect to see the other mutations in this particular tumor. So they are individual, independent drivers of the development of thyroid cancer. Now, in the United States, the biology of papillary thyroid carcinoma has markedly increased, and you can see it in this very interesting graphic. By 1996 to 2000, for instance, if you look at the incidence of red PTC rearrangements, it was about 40% of all cases who have papillary thyroid carcinoma. In reality, by 2010, the presence of red PTC rearrangements has markedly decreased. Conversely, there is an increased incidence of BRAF mutations. Why is that? We don't really know, perhaps because of biological aspects located in the environment, but in reality, the nature of the disease, at least in the United States, related to papillary thyroid carcinoma, has markedly changed over the last 10 years. Now, let's talk about some epidemiological factors associated with papillary thyroid carcinoma, gender and race. Is there any difference in between gender and race for the presence of papillary thyroid carcinoma? As you can see in this graphic, yes, women have a higher tendency to present with papillary thyroid carcinoma when compared with men. However, there is no difference in race. So that's a very important aspect. Now, in regards to age of presentation, it seems that papillary thyroid carcinoma has, in average, a presentation that is a little bit younger in women than men, with a median age at diagnosis in women in the United States of 49 years, while in men, the median age of diagnosis is about 54 years. Now, is there a difference in regards to prognosis in genders? The answer is no. The disease-specific survival for both women and men, as you can see in this graphic that compares with the survival of the general population, in reality is quite excellent. So this is a disease that for most part still behaves in a normal way in many different patients who have or who suffer from it. Let's talk now about the principles of therapeutics for papillary thyroid carcinoma. When you look at papillary thyroid carcinoma, 90% of patients who have papillary thyroid carcinoma will present with a disease that is localized in the neck. And for that disease, we use several conventional therapies that include surgery, radioactive ion ablation therapy, and thyroid hormone suppressive therapy, and this is the group of patients that is usually cured from the disease. Then, in 10% of patients with papillary thyroid cancer, we may have disease that is associated with distant metastases. Those distant metastases happen mainly in the lungs, followed by the bones. In 1/3 of them, the disease they have is responsive to radioactive iodine ablation therapy and thyroid hormone suppressive therapies, and in some of them, the disease can be cured, and in those in whom the disease is not cured, the disease might be very well controlled over the years. They represent about 4% of the total cohort of patients with papillary thyroid carcinomas. There is, however, an exceptional group. 2/3 of the patients who have distant metastases may present with disease that is resistant to radioactive iodine ablation therapy and thyroid hormone suppressive therapy, and these are the patients that represent a real troublemaker to all us in clinical practice. I'm sorry. So this is an important part in regards to the classification of papillary thyroid cancer. So let's talk about the treatments for papillary thyroid carcinoma. The initial treatment for papillary thyroid carcinoma is a total thyroidectomy. Surgery is extremely important, and a total thyroidectomy is optimal for patients who have tumors that are at least 1 centimeter in diameter. For patients who have tumors that are smaller than 1 centimeter in diameter, yes, a subtotal thyroidectomy or a lobectomy may be just enough. But for patients who have tumors that are bigger than 1 centimeter, it is recommended to do a total thyroidectomy. Why a total thyroidectomy? The reason is simply because the period of time free of recurrence gets improved just by doing a total thyroidectomy. Surgery in patients with thyroid cancer, in particular with papillary thyroid carcinoma, is associated with an improved survival. And you can see it in this graphic when you compare with patients who do not have a total thyroidectomy. In red, patients who had a total thyroidectomy. In yellow, patients who didn't have a total thyroidectomy. And the overall survival in patients with tumors that are bigger than 1 centimeter in size is markedly increased. For patients with a stage 3 and a stage 4 thyroid cancer, which are more advanced cancers, still a total thyroidectomy is recommended, and you can see that the survival rate of those patients is markedly improved when compared with patients who have had less than a total thyroidectomy in clinical practice. So surgery in reality has a very important impact on survival and recurrence rate on patients with papillary thyroid carcinoma. As you know, the thyroid cancers, in particular papillary thyroid carcinoma, follicular thyroid cancer, and Hartle cell thyroid cancer, because of the origin of the follicular cell, may have the capacity to express the sodium iodine transporter in the cell membrane. And because of that, they may be able to uptake iodine from the blood and may be able to concentrate iodine in order to create thyroglobulin and thyroid hormone that will later on be secreted into the blood. Well, we may label the iodine with radioactivity, and by making that, we are going to use this as a tool in order to destroy the follicular cell that is abnormal, in this particular case, a cell of papillary and follicular thyroid cancers. And that's the principle that we have in order to do or to use the postoperative radioactive iodine therapy in the treatment of this particular disease. Postoperative radioactive iodine therapy has two different benefits. One relates to adjuvant therapy and another one as a remnant ablation. Let's talk about adjuvant therapy. In the case of adjuvant therapy, the postoperative radioactive iodine therapy will eradicate any post-surgical microscopic as well as macroscopic thyroid carcinoma that may be located in local remnant or regional and distant metastases. In this case, the target cell is the malignant cell of thyroid cancer, and the expected outcomes, if it is really beneficial, will be a prolonged time to recurrence, an improved disease-free survival, and an improved survival as an adjuvant therapy. Now, let's talk about remnant ablation. In the case of remnant ablation, the actions of radioactive iodine therapy after surgery will be to destroy any remaining normal thyroid tissue as a source of thyroglobulin, as well as improving the radioactive iodine uptake in these particular patients, improving also the accuracy of the follow-up whenever you follow on patients with papillary thyroid carcinoma. In this particular case, the target cell is the benign thyroid cell that has been left by surgery. Many times, the surgeons are not able to remove completely the thyroid gland. And the reason why they are not able to remove completely the thyroid gland is because the posterior capsule of the thyroid gland is attached to very important structures such as nerves, arteries, and veins that regulate our voice. That area may be a false positive source for thyroglobulin as well as iodine uptake in clinical practice, and that's the area that we are going to target mainly by using postoperative radioactive iodine therapy as a remnant ablation therapy. The expected outcomes, if beneficial, is of course will improve the survival of all these patients. It will decrease the time to detection of a recurrence because it makes the follow-up much easier, and it may worsen the disease-free survival simply because it will allow the discovery of the tumor if it comes back or if it stays despite of surgery in a much more effective manner. When you look at the improved survival that we may see in patients with radioactive iodine therapy, you can see it in this graphic, which is quite important, published in 2001 in JCNM. In this graphic, you can see the disease-free survival in the y-axis. In the x-axis, you will see the years after initial therapy. In the circles that are empty, you will see patients who were not treated with radioactive iodine therapy or thyroid hormone suppressive therapy. In the black diamonds, patients who were treated only with thyroid hormone. And in patients in triangles, patients who were treated with thyroid hormone and radioactive iodine ablation therapy. When you look at the graphic, patients who were treated with radioactive iodine therapy exhibit a much better disease-free survival when compared with patients who didn't receive any treatment or patients who were just treated with thyroid hormone suppressive therapy. In regards to prognosis in different stages, you will see that in stage 2 papillary thyroid carcinoma, for instance, the radioactive iodine therapy here in red is associated with a better overall survival when compared with the one that we see in patients who didn't receive radioactive iodine therapy. And this is also true for patients with advanced disease, stage 3 and stage 4 papillary thyroid carcinomas, in whom the radioactive iodine therapy is associated also with a better overall survival whenever responsive when compared with patients who have not received radioactive iodine therapy. The very important therapeutic modality for patients with papillary thyroid carcinoma is represented by the thyroid hormone suppressive therapy, and in this one we use the TSH receptor as a target for therapy. In this graphic, you can see that the TSH receptor is located in the left side. This one interacts with the TSH, and the interaction with TSH will allow the activation of the G-stimulating alpha protein inside the cell that will activate the adenylate cyclase system that will finally induce cell differentiation and cell proliferation. So it makes a lot of sense for patients with papillary thyroid carcinoma to receive then a high dose of thyroid hormone in order to suppress the production of TSH and to decrease the activation of this particular pathway. People have questioned if the use of thyroid hormone could have really improved the overall survival of these patients, and the answer is yes. Thyroid hormone suppressive therapy is associated with a better overall survival. You can see it in this particular graphic in patients with small tumors. Many times, just by keeping an undetectable to normal TSH values, the survival rates are better than just by keeping patients with a normal to elevated TSH values in plasma. So it has an important role. And if you look at patients who have very advanced disease, stage 3 and stage 4 papillary thyroid carcinomas, you may see that by keeping a TSH in between numbers that are undetectable to low normal, the survival rates are better than the ones that you see in patients in whom the TSH is in the low normal values to elevated values in clinical practice. Let's talk now about some risk factors for prognosis. There is something that is interesting in the United States, and it's also happening in some countries in Europe, and we have some information that is not published, but it's important to keep in mind. The incidence of papillary thyroid carcinoma has markedly increased, as you can see in the left side of this graphic, and is perhaps the type of cancer that has increased in maximal amounts the incidence when compared with others over a period of 10 years from 2001 through 2010. When you look at the mortality rate of papillary thyroid carcinoma, you will see that this is one of the cancers in which the mortality rates have markedly increased too. This is quite, I'm sorry. This is quite interesting because if you look at the progress that we have made in cancer, the survival rates of all other cancers have markedly improved, different with the ones that we see in papillary thyroid carcinoma. And I'm going back to this graphic. What are the cancers in which we see an increased incidence and mortality? The cancers in which we have seen an increased incidence and mortality in the United States are liver and bile ducts, followed by thyroid cancer, followed by pancreatic and melanomas, and by tumors located in the uterine body, in particular sarcomas. In all the other cancers, including lung, breast, prostate, colon, etc., the survival rates in the United States have markedly improved thanks to the introduction of new therapies. Now, this is asking us, what are the factors that determine the prognosis of papillary thyroid carcinoma? So there are several factors that we have to keep in mind. Number one, the size of the primary tumor. When you look at this graphic, you can see that for patients who have papillary thyroid carcinomas that are bigger than 4 centimeters in size, the survival rates are decreased, as well as the recurrence rate. So the primary size of the tumor is an important risk factor to determine the prognosis of these particular patients. Another important one, the extension of the disease. Without talking about the stages, we can classify papillary thyroid carcinomas in local, in red, as those that are located exclusively in the thyroid gland. In yellow, those who have spread into regional lymph nodes, and in green, patients who have distant metastases with metastases into the lungs and into the bones. When you look at the 5-year relative survival, the age at diagnosis and the disease extent, you can see that in those patients who have distant metastases, the survival rates are much less when compared with the ones with patients who have just regional or local disease. And an important aspect that you can see here is that after age 45, the survival rates also decrease. So age is another important risk factor for prognosis in patients with papillary thyroid carcinoma. And that is confirmed in this graphic, in which you can see patients who are older than 65 years of age, in whom the survival rates, the aggressiveness of the disease, are markedly increased when compared with people who are younger than 65 years of age. So we have age, we have extension of disease, and we have primary tumor size. Now, this is going to place these characteristics in our current staging of papillary thyroid carcinoma. According to the American Joint Commission for Cancer, for instance, based on age, we can classify papillary thyroid carcinomas in stage 1 and stage 2 only. Whenever the patient has younger or is younger than 45 years of age, the papillary thyroid carcinomas will be classified only as stage 1 and stage 2. But for people who are older than 45 years of age, papillary thyroid carcinomas will be classified as stage 1, 2, 3, and 4. So age is an important predictor of prognosis. Now, when you look at the stages of papillary thyroid carcinoma, they per se are associated with prognosis. Stage 1 exhibits the best overall survival. Stage 2 is less survival than stage 1, and of course, stage 3 and stage 4 will exhibit a decreased overall survival when compared with stage 1 and stage 2 stages of papillary thyroid cancer disease. So what we have seen so far is that papillary thyroid carcinoma is a disease in which the prevalence has increased, and it has increased apparently by 77% in the United States and most likely in most countries around the world. The new cases have increased by 155% in a period of 10 years, and very important, we have noticed that the mortality of thyroid cancer has markedly increased too. Why is the mortality increasing? Because in a higher risk of distant metastatic disease with progression, and usually disease that is not responsive to iodine and thyroid hormone replacement therapy, and I'm going to discuss that in a further lecture tomorrow. So in conclusions, we can say that papillary thyroid carcinoma is common, with most presenting disease as a low-risk disease, as the disease is rather small than big. The incidence is increasing more than mortality. Small tumors are increasing faster than large. The etiology is likely multifactorial, and the treatment heterogeneity has significant implications for clinical outcomes. And with this slide, I finish this presentation. I'm not really sure if we have time for questions, but thank you for your attention.